Hello and welcome to today's webinar, Get the Facts on Reporting Medicare's Appropriate Use Criteria Data and Claims. Thank you for joining us, and before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a question and answer session. In your GoToMeeting control panel, you'll see a questions box. Please type your questions or comments into the field and hit enter. Please note that the recording of this webinar, along with the slide deck, will be posted to the WEDI website, and downloading instructions will be emailed to all registrants. And we actually already have the PDF of the slides up in your GoToWebinar control panel. It's in the handout section of the panel. Without any further ado, I'd like to go ahead and hand it over to Nancy Spector.
Thanks, Sam. We will go ahead and get started with the presentation. I will begin by introducing myself. I'm Nancy Spector, and for purposes of this webinar, my role is chair of the National Uniform Claim Committee, and I will let Todd and Fred introduce themselves. Todd?
Thanks, Nancy. I'm Todd Amundsen, and I work for the AHA, and I'm basically the acting chair of the NUBC.
And I'm Fred Rook, and I currently work in the Provider Billing Group at the Centers for Medicare and Medicaid Services.
Thanks, and I'm glad to have both Todd and Fred on the webinar as we talk about reporting the use criteria, data, and claims. So just to give you an overview of what we're going to talk about on the webinar today, we're going to start with talking about just the background on the appropriate use criteria program, the 4 different parts of the program, and then we'll get into the reporting requirements and some claim examples, and we'll end with some time for questions and answers. And just to also give you some information here at the beginning, there's a slide at the end as well. But there are, CMS has on their website different pages of information about the program and its various parts. So if you go to cms.gov and then in the search bar, if you put in AUC, it'll take you to the different pages that they have within their website. And there is a link to that and some of the different resources at the end of the presentation. So the appropriate use criteria came about through the Protecting Access to Medicare Act, which is commonly referred to as PAMA. And within PAMA, it required the Secretary of HHS to establish a program to promote the use of appropriate use criteria for applicable advanced diagnostic imaging services provided in applicable settings by ordering and furnishing providers. So very specific in terms of what was being asked there. And the intent of the Medicare program is really to look at the appropriate use of diagnostic imaging services and decrease the use of inappropriate services. And it's doing this by giving the ordering provider evidence-based guidelines about imaging services for specific clinical scenarios and the patients presenting symptoms or conditions. And through this, the provider will then have information at the time that they're ordering the service and will be able to make the best decision for the imaging service based on the appropriate use criteria and the patient's diagnosis or symptoms. And some of these definitions too, we'll go through definitions because some of these terms are specific to this particular legislation and the regulation. The specifics of the program, the different regulatory actions that have been coming through, have been coming through in the yearly physician fee schedule final rule. So that's where if you're looking to find out more specific information about the requirements, it's the physician fee schedule rules that you would be looking at. Definitions wise, like I said, I'll go through these definitions to give you a better understanding of what is meant by all these terms. So the appropriate use criteria is criteria that's been developed or endorsed by national professional medical specialty societies or other provider-led entities. And they are to assist the ordering professional and the furnishing professional in making the most appropriate treatment decision for a specific clinical condition for an individual. And when they're talking about applicable imaging services, they're talking about advanced diagnostic imaging services for which there is one or more applicable appropriate use criteria and one or more qualified clinical decision support mechanisms. We'll get to that definition here in a second. And the provider-led entities, these are national professional medical specialty societies or other organizations comprised primarily of providers who either within the organization or outside of the organization predominantly provide direct patient care. So these are really these entities are really looking at this from the provider specialty and the provider perspective. The clinical decision support mechanism, this is an interactive electronic tool that is being used by the provider, and it communicates the appropriate use criteria and assists the user in making the most appropriate treatment decision for a patient-specific clinical condition. And these tools can be modules that are within or available through the EHR, or they can be separate from the EHR. And we'll get into talking more about this as we go through the slides. We've got the ordering professional, which we typically just say ordering provider. And this is a provider or practitioner who orders an applicable advanced diagnostic imaging service. And in the 2019 physician fee schedule rule, this definition was expanded to allow the appropriate use criteria consultation to be done by a clinical staff member under the direct supervision of the ordering professional. Then we have the furnishing professional. Again, this is what we would typically call the rendering provider. And this is the provider who furnishes the applicable advanced diagnostic imaging service. And then we've got priority clinical areas. And these are the clinical conditions, diseases or symptom complexes, and associated advanced diagnostic imaging services that have been identified by CMS and may be used in the determination of the outlier ordering professionals. And we'll get to that at the end about the outlier. So let's move along and go through the different parts of the program. To begin with, as we talk about advanced diagnostic imaging services, what we're talking about here, and these are the examples that are given within the regulation, we're talking about the CT scans, your MRIs, PET scans, and nuclear medicine. And often people are asking the question about, well, when does the appropriate use criteria program, when does this come into place? When do we need to be concerned about this? So it applies when you have an advanced diagnostic imaging service being provided. You've got a patient who's being covered by Medicare. The imaging service is being performed in a physician office, a hospital outpatient department, including the emergency department, an ambulatory surgical center, an independent diagnostic testing facility, or any other provider-led outpatient setting that CMS would determine to be appropriate. And the fourth piece to this is that the service is being paid by Medicare using either the physician fee schedule, the outpatient prospective payment system, or the ambulatory surgical center payment system. Those are the situations, if all of those are applicable to the patient and the service being performed, then the appropriate use criteria requirements come into place. And as I said, we've got 4 parts to the program, and we'll start with part 1, which was establishing the appropriate use criteria. And so this started in 2016 with the fee schedule final rule, and it set out what the requirements are for the PLEs, the provider-led entities, and their qualifications. And So what we have are these provider-led entities, and those are the groups that actually set the appropriate use criteria. And as I had said in the definitions, the PLEs are these national professional medical specialty societies, and they are qualified by CMS. And there's just a partial list of what it takes to be qualified to be a PLE. They must use evidentiary review process when developing the appropriate use criteria. They use at least one multidisciplinary team with autonomous governance, decision-making, accountability for developing the appropriate use criteria. They publish each individual criterion on their website. They identify each criterion or a subset that are relevant to a priority clinical area, and they use a transparent process for the timely and continual updating of each criterion. So again, this is just a partial list of what it takes to be required. I just wanted to give you an idea of kind of the rigor that goes behind being an entity that establishes the appropriate use criteria. And then this is the list of the organizations that have been qualified as PLEs as of June of 2019. So you can see you've got a broad mix of different organizations who are qualified to do this appropriate use criteria development. The second part of the program is the establishment of the mechanism for the consulting the appropriate use criteria. So in 2017, the Physician Fee Schedule Final Rule created what's called the Clinical Decision Support Mechanism, or CDSM. And again, going back to when I spoke about this in the definitions, this is an interactive electronic tool that is used by the provider to query the appropriate use criteria. And again, these can be modules that are contained within the EHR, or they can be separate from the EHR. And again, these entities are qualified by CMS, and there is, again, a list of requirements that they must meet in order to be qualified. And again, I've given just a partial list of what those requirements are, so you can get a sense of what it means to get qualified to be a CDSM. You can see here that they make available specified applicable AUC and related supporting documentation. Just going to skip through a few of these, but they make available at a minimum specified applicable AUC that reasonably addresses common and important clinical scenarios within all priority clinical areas. They're able to be incorporated. They're able to incorporate specified applicable AUC from one or more qualified PLE. And the final one listed here is that they're able to provide the ordering professional with an aggregate feedback regarding their consultations with the specified applicable appropriate use criteria. So this is pretty complex, pretty detailed, you can see, but it speaks to exactly, how rigorous the process is for becoming a qualified CDSM and being able to be included within the program. And this is the list so far as of June 2019 of the qualified CDSMs. And you'll notice that there's asterisks next to a few of these, and that means that they are free tools. So those are tools that would be available free of charge. Moving on, we'll talk about next the appropriate use criteria consultation and reporting. And this is probably the most complex part of the program. And this is where it comes into play, where the ordering provider is going to be querying the CDSM, reporting to the rendering provider the appropriate use criteria data, and then the rendering provider is going to be reporting that data in the claim. So we have here that PAMA specifically requires these three pieces of data to be reported in the claim for advanced diagnostic imaging services that are provided. And so the first is the CDSM that was consulted by the ordering provider. Second is whether the service adhered to the applicable appropriate use criteria, did not adhere to the AUC, or whether no criteria in the CDSM were applicable to the patient's clinical scenario, or whether there was an exception that applies. And finally, the third element is the NPI of the ordering provider. In terms of the first requirement, which is the CDSM that was consulted by the ordering provider, go about reporting this in the claim, CMS established HCPCS G codes to identify the CDSM that was queried. And the HCPCS G code will be assigned, there will be a HCPCS G code assigned to each qualified CDSM. And that G code is going to be reported as a separate service line in the claim. And we're going to go through some of those examples, and you'll be able to see how that looks within the claim, within a professional and institutional claim. And this is the list of the HCPCS codes that are assigned to the qualified CDSMs as of July 2019. This is the list. And you'll notice that the last G code there is one that says that it's a qualified tool that not otherwise specified, meaning that there may be a qualified tool that's been posted to the to the CMS AUC website as being a qualified tool, but it hasn't yet gotten its HCPCS G code assigned just because of the timing of how that happens. And so if there is a qualified CDSM, you can still use that, and then you would use this G code G1011 to identify that it's qualified tool, but it hasn't yet been assigned its own specific G code. So there is an ability to work with that. So I mentioned that there are exceptions for when you would need to consult the CDSM. And these are the specific exceptions that have been outlined in the regulation. One is emergencies. The second is that it's an inpatient advanced diagnostic imaging service. And the third is when the ordering provider meets one of the following hardships exceptions. And they are insufficient internet access, an EHR or CDSM vendor issue, or extreme and uncontrollable circumstances. And to report on the response from the CDSM, what CMS has done is they have created HCPCS modifiers to identify that specific response. And the modifier will be reported on the same service line as the procedure code for the advanced diagnostic imaging service. And the modifiers as of July 2019 are listed here. So you can see here there are 8 modifiers that have been created, and you have one for the different potential scenarios that will come into play. First being that there's an emergency medical condition. Second is that there's insufficient internet access. The third is an electronic health record or CDSM vendor issue. MD is for extreme and uncontrollable circumstances. ME then is saying that the service does adhere to the appropriate use criteria. MF is that it does not adhere to the appropriate use criteria. MG is saying that the service, that there's no appropriate use criteria, meaning there was nothing applicable in the CDSM that was queried applicable for that patient's condition or diagnosis. And then the final modifier is that it's unknown if the ordering professional consulted a clinical decision support mechanism. So essentially what this is saying is that the information about the CDSM or whether or not it adhered was not reported to the rendering provider. So that would be the qualifier that would be used. So how this happens then within, we've talked through the different how you report the CDSM, how you report the response. And then we have the ordering provider MPI. And on the professional claim, this is reported as you would do today for any ordering provider. It's reported in item number 17 on the 1500 form, which is the name of the referring provider or other source, and you would be using qualifier DK for ordering provider. And in the in the electronic claim, you would be reporting this in loop 2420E, where you've got NM1 ordering provider and the NM109 identification code. So Todd, do you want to talk about the institutional reporting?
Well, the institutional 837 nor the UBO had a data element for ordering provider. So we had to do a couple of workarounds. And for the electronic, they basically designed a K3 segment to be used. This is similar to, if you recall, present on admission was reported initially with a K3 segment until there were actual data elements opened up in the TR3. So on the UBO4 form, what we're doing, we've done this a few times, using form locator 43 because it's long enough. It's like 24 bytes. Using that for the NPI of the ordering provider. Anything else,
Okay.
Greg? Yeah, that's.
Okay. So moving along then, we've got the looking at this from the overall workflow of the appropriate use criteria. And what we have here is, just to walk through a general scenario of how this would work. So you would have a provider seeing a patient who's a Medicare beneficiary, and the provider is planning to order an advanced diagnostic imaging service. And so what they would do is the physician or a clinical staff member under the direct supervision of the physician would be consulting the appropriate use criteria for the proposed service through the CDSM. And that would be either integrated in the EHR or it would be a separate portal. So essentially, either within the EHR, as they would be ordering this, there would be an ability right there to query into the CDSM, or it could be a separate website or a separate portal in some way where the person doing the querying would need to enter the information into that system and generate that response. So in this situation here, though, if you've got a hardship exemption that's in place, then the ordering provider would be including that information with the order, and they wouldn't need to be querying the CDSM. But moving on to the next step, within the CDSM, as it's being queried, it will search through the appropriate use criteria that's built into it, and it will look for appropriate use criteria that are relevant to the patient's condition. And then it's going to respond back with an answer as to whether or not the proposed service adheres to the appropriate use criteria, does not adhere, or if there was no applicable appropriate use criteria in the system. And so if the service adheres to the appropriate use criteria, the provider would then proceed with ordering the service as they would typically order a service. If it does not adhere to the appropriate use criteria, then the provider has to make a decision. They either need to decide whether or not they're going to order a different service, or if they're going to go ahead and proceed with that service that they were planning to do, even though it's not adhering to the appropriate use criteria. And then the provider would go ahead, do the order with however they would normally do their orders. And with the order, they would be including the CDSM queried, the appropriate use criteria response, and their MPI. And then you would have the patient would go off, they would undergo the service by the rendering provider. And then the rendering provider would be reporting in the claim both professional and the institutional, the CDSM HCPCS G code, the AUC modifier, and the ordering provider's NPI. So let's move through and let's walk through a couple examples and show how this would look on the claim. So the first example is that we've got a patient, John. He's being seen by his primary care physician, Dr. James Smith, and he's complaining of lower back pain after falling on the ice 4 days ago, and the pain has been persistent, and he intermittently has radiating pain down his right leg. So Dr. Smith is planning to order an MRI of the lumbar spine, and he queries the CDSM. The CDSM responds indicating that the MRI adheres to the appropriate use criteria. So Dr. Smith proceeds with ordering the MRI and includes the HCPCS G code, modifier, and NPI with the order. And so John, our patient, then goes to the outpatient hospital department and has the MRI done. So on the professional claim, on the 1500, what you would see is you have the ordering provider there in box 17 with the qualifier DK, and you've got the NPI there in 17B. And then on the service line levels, so this, when I was saying this earlier, I'm not sure if it made sense, but here you can see how you're going to be reporting separate service lines for the HCPCS G code for the CDSM, separate from the service line that has the procedure code and the modifier for the AUC. So you can see here, you've got your dates of service, you've got the service location in 24B, then you've got the CPT code saying what was done, the modifier ME, and that's the modifier that says that the service adheres to the appropriate use criteria, and the remaining information that would go on that service line. And then that second service line is where you've got, again, the same information with the dates, the place of service, and now you've got the G code that's indicating which CDSM was queried. And then in the 837P, this is showing you what that information for those particular lines would look like, those particular pieces of information. So you've got the two service lines with the procedure codes, the HCPCS codes, and then you've got the ordering providers NPI. So let's see how it looks in the institutional claim.
Well, we've got two options here. The only option is the revenue code. It's a different revenue code. But for all the advanced imaging services, there are revenue codes right in the manual. Pretty obvious revenue codes. Now, I just want to start by saying these are just for illustrative purposes only. May change. For instance, we've got that DK on the description. That may or may not be necessary. But let me just go forward. Also, it's kind of ordered. The 837I is ordered sort of in the way of the claim, just to show it kind of a logical order. It's got the 301, the K3 at the bottom, but in the actual transaction, it'll be near the top. But we just did it this way to show the services first. And let me see. It's just cutting off my screen. So we've got the same CPT codes. I think they're the same on both, I would hope. And service units and we've got total charges there on the charge line. The second line is the G code line, which identifies the CDSM. And it says we've got $1 for total charges there because that code is not payable. And if it may be necessary for operational purposes, to use a nominal amount in order for the claim to process. We chose a nominal amount of $1, and Nancy chose a nominal amount of a cent, a penny. I've heard that some systems cannot handle a penny, so we went with the $1.
Okay. So let's move on and look at a few more examples. So our next example is patient Jane. She's brought into the emergency department via an ambulance following a car accident. She's unconscious and unresponsive. Dr. Mary Jones orders a head CT, see if there's any intracranial bleeding. And because it's an emergency, Dr. Jones does not query the CDSM for the appropriate use criteria. So the CT scan is performed in the hospital's radiology suite, and it does show that there's been intracranial bleeding. On the 1500, this would be how it would look. You would have, again, your ordering provider, NPI, and then you've got in the service line area, you've got the dates of service, the place of service, and then you've got the CT, the procedure code for the CT scan that was performed. You've got the modifier MA, which equates to it being an emergency medical condition. And then you have the remaining information there on the service line. And in the 837P, you would have, again, the one service line showing the procedure code that was performed, the modifier, and then you have your line where you would show the or report the ordering provider's NPI. So then with the institutional claim, you have this.
We have, starting out with the revenue code for that procedure. We've got the 10-digit NPI next to it. And then we've got the CPT code. In the modifier section, we have got an MA, which, as Nancy said, it's a suspected or confirmed emergency situation condition. 1 unit, the total charges are 1,000. Now, we didn't have to do a CDSM on this, so there is no CDSM line and no nominal charge on that line.
Okay. And then next example, we have another example. This is patient Bob, and he arrives in the hospital radiology outpatient department with an order from his physician Bill Johnson, and it's to have a CT scan of the abdomen. There's no information about the CDSM or the appropriate use criteria included with the order. The CT scan is performed. And so what we would see on the professional claim, again, we've got the ordering provider NPI being reported. We've got the service line, again, with the place of service. You've got then the procedure code of this abdominal CT scan that was performed. And in this case, we've got modifier MH, which stands for unknown if ordering professional consulted a clinical decision support mechanism. And then the remaining information there. And so with this particular service, again, you would only have one line. You would have the procedure code, the modifier, and the remaining information. There's no second line to report here because there was no information passed along about what CDSM was queried or if a CDSM was queried. So there's no second line to report here. And then of course you got your line with the ordering provider's NPI.
Just want to make a comment here. It's allowable to have more than one CDSM on a claim. They just have to be on different lines. On the institutional, I think that's where we're going next. Starts off with the revenue code. That is the revenue code for CT body scan. We've got the HCPCS code for a CT body scan. Got the MH again, which means it's unknown if the ordering professional consulted a CDSM. So therefore, there's no CDSM line. But we've got below, we've got the revenue, the lines and the K3 segment detail.
Okay. And then one final example showing the more complex multiple services here. So we've got Sue, our patient, is undergoing treatment for metastatic ovarian cancer that has spread to the brain and chest. Her oncologist, Dr. Mary Davis, orders CT scans of the pelvis, chest, and head to assess the progression of the disease. The CDSM queried by Dr. Davis indicates that the CT scans meet the appropriate use criteria. And Sue goes to the off-campus provider-based outpatient department and has those CT scans performed. So on the 1500, here you're seeing that you've got a service line for the CT scan, and then you've got a service line for the CDSM that was queried. And that repeats for each of those scans. So you've got that first line is the, if I'm right on my CPT codes, the first one is the CT of the brain. And then the second line is the CDSM that was queried. The third line is the CPT code for the chest CT scan and the modifier that says that it met the appropriate use criteria. And we've got the fourth line is, again, the CDSM that was queried. And we've got then the fifth line is the CT scan of the pelvis with the qualifier ME. And then the sixth line is showing the CDSM that was queried. And I think what, Todd, what you were saying too is a minute ago was that it could be different CDSMs. In this particular example, we made it that it was the same CDSM that was queried for all three exams, but you could have it where for whatever reason, it's a different CDSM that maybe there's a differentiation between, say, maybe the head CT versus the pelvic CT. Maybe it's different criteria that were developed by the different entities, PLEs, and so they were in different CDSM tools, and so you're querying different CDSM tools for those particular diagnostic imaging studies. So like I said, you could have different CDSMs, but in this particular example, we kept them all the same. So let me move ahead and we can see how that looks in the professional. So again, you would just have those 6 different service lines in the professional, the 837. And then again, still your line with the ordering provider MPI. And then this is how it will look on the institutional.
Okay, we've got 4 lines. We got revenue codes on all 4 lines. 43, the bottom one actually has a description of the revenue code since we don't need it for the NPI. So we've got the first line is a head scan revenue code. Second one is a body scan CT, and the third one is also a body scan CT. Now, what we have here is the only example that has 2 modifiers. Every claim has to have a what I call an AUC modifier, adhered, not adhered, etc. But which is ME on this one, which is adhered. There's also the PO modifier, which is used for what's called accepted off-campus provider-based facilities. And accepted, that just means that it's paid under OPPS. It wasn't accepted to be paid under the fee schedule. So I just wanted to show that you can have more than one modifier on a claim. And so that was an example of that. So-called, I call it a regular modifier. There's room on here on the 837 and the UB for four modifiers. That's all you have room for is four. The 7030 will have room for 8 modifiers, so you can go wild on modifiers if you need to. So I think that's all on that.
So before we didn't do a specific example for this, but I know it came up in our discussions. I don't know, Fred, if you want to speak to it about the critical access hospital.
Right. So I think, Nancy, well, we found out in looking into the critical access hospitals, and again, I'm not sure there's a definitive answer on this at this point, but I don't believe critical access hospitals were one of those locations that were listed as requiring the AUC.
It's not an applicable setting.
It's not applicable setting. It doesn't appear to be. So, once I think that's finalized, I'm sure we'll publish something out there to, clarify that for everybody. But it didn't appear in the list of the applicable settings.
Although we had a great example for it, though.
Okay, so that is several examples where you could actually see, a particular scenario and then how that would translate, how that would look on the claim. So just to round out, that it was section or part 3 of the appropriate use criteria program. Part 4 is the identification of outliers. And this is the final part of the program. And what it is that PAMA calls for the identification on an annual basis of no more than 5% of the total number of ordering providers who are outliers. And 2 years of Medicare data will be used to do the analysis for the outliers. And outliers are going to be determined based on low adherence to applicable appropriate use criteria or comparison to other ordering providers. And providers who are found to be outliers will be required to complete prior authorizations for advanced diagnostic imaging services for their Medicare patients. CMS is still in the process of developing they're still developing the process to identify the outliers, and we are expecting that further details will come in future regulations about that. I spoke earlier about the priority clinical areas, and the appropriate use criteria data must be reported for all diagnostic imaging services. But the focus of the analysis for outliers will be on the priority clinical areas. And at this time, these are the 8 priority clinical areas that have been identified. Now, CMS does have the ability to add to this list over time. But right now, we've got coronary artery disease, suspected pulmonary embolism, headache, hip pain, low back pain, shoulder pain, cancer of the lung, and cervical or neck pain. So those are the areas that those specific clinical diagnoses where they will be analyzing the provider's ordering patterns to identify outliers. The start date for all of this is January 2020. January 1, 2020 is going to be an educational and operations testing period. And so during this 1 year, first year, it's going to be optional to report the appropriate use criteria data in claims. Obviously, highly encouraged to begin doing this in order to prepare for the full implementation. During the 2020 year, this educational and operations testing period, claims that are submitted without the appropriate use criteria data or without the correct data will not be denied. So this is a testing period giving providers time to familiarize themselves with the appropriate use criteria requirements, develop an action plan for compliance, and test their systems. And then as of January 1, 2021, that is expected to be the deadline for full implementation. And claims will be denied after January 1, 2021 if the appropriate use criteria data is not being reported. And just to clarify, that claims will not be denied if the service performed did not adhere to the appropriate use criteria. So it's that the data has to be reported. Whether or not it adhered or did not adhere is not does not affect whether or not the claim is being paid. So that is the information about the start date. And then these are some of the resources I was telling you about. So this is the CMS website that will take you to where the appropriate use criteria program information is listed. We also have the link to the MLN article that was published on July 26th. And there's also the X12 RFI that talks about how to report the ordering provider in the institutional claim. We also have the email address for the Medicare question email box, and this is specific for the AUC program. So it's imagingauc@cms.hhs.gov. So with that, we can open it up to questions and answers.
Thanks, Nancy. The first question, what is the time frame for the CDSM to respond to the request from the ordering provider?
So my understanding is that it's all real time, that this would be happening in real time. So I'm not sure exactly, you know, how many sort of seconds or minutes it takes for the response to come back, but it's not like where you would enter it in and then you would have to, you know, wait some period of time and come back to get the response. It's all supposed to happen in real time.
Why is the ordering on the UB form being mapped in box 43? Can it be mapped in box 79 under other with the DK qualifier?
Well, I suppose, but we've used this technique before for rendering physicians on a line item. The thing is, it has to be on the line. It's a line item ordering provider. In 79, no, that's a claim level provider, right? It says other, it's claimable. We don't have it. We don't even have a qualifier for that, and there's not a claim level ordering provider on the 837 either. The reason it's on 43 is because it's line item specific. Now, if X12 decides they want to have a claim level ordering provider, we'll follow, but we're not going to lead on that. Because the thing is, if they did that, it wouldn't happen until after 7030. So it's the next version after the expected next version. So let me say also, the K3 is only for 5010 claims. And once the 7030 comes around, hopefully we won't need the K3 anymore.
Next question, what is the XYZ on line 4, slide 36 represent?
Let me go back to that slide.
Yeah, this is Fred. I could take that one. So because the CDSM G code G1011 is a not defined G code, then the SV207 has to be filled out identifying which CDSM was used. And so this is that time frame where Nancy mentioned a CDSM has been approved, but it does not have its own individual HCPCS code to represent it. So at that point, you would identify that CDSM in that seventh segment of the SV2 line. And I think currently there are 4 of those that qualify under being able to use G1011, that the tool is not otherwise specified. And so for those 4 current ones and any ones that are approved prior to having their own G code, then the providers would be using that HCPCS code and then qualify the HCPCS code with the other identified information.
So the colons just represent places when they're not filled out.
Right, so the XYZ currently, I mean, that are out there are the Agile NDs, clinical decision support mechanism. Another one would be like evidence cares, imaging advisor. So if that was a CDSM that was used in making that clinical decision, then your SV207 would have CDSM, evidence cares, imaging advisor.
Thanks very much. The next question, do the clinical systems have to provide patients with a printout from the CDSM vendor with the AUC codes at the time the order, or is it sufficient to capture the AUC codes within the order in the EHR and have the CDSM vendor store a document that also captures all of the consultation information that can be accessed or pulled up at any time if needed?
So I think what I'm hearing in there is that the way that the program is set up is that the information is to go with the order. The CDSM and the modifier is to go with the order, so that the rendering provider then has that information and can enter that on the claim. I think what we're not getting into and talking about this because we're just talking about what the program itself requires, but organizations are going to have to look at, if you're within an organization, a large, hospital system where you're doing orders and you're doing services and you're on the same EHR system, you'll be looking at how exactly that information is going to move from the ordering to the rendering, versus if you're, an ordering practice that's independent or separate potentially from the locations where the services are going to be provided, and then how that information is going to move with the order to the rendering provider. So I'm not sure if that's part of what's getting at here. I did hear in there the part of it is that, in my understanding, I'm not an expert on the CDSMs, but my understanding is that they do have sort of a function where it stores the information about the queries and the responses given, and that's something that could be auditable. I'm not sure exactly, how that could play into the program overall, but my understanding is that the CDSMs do store the queries that happen and the responses that they give. But that, in terms of a printout, I'm not clear on whether or not CDSMs would provide something of a printout or not. I'm not sure if that really answers the question, and I don't know, Fred, if you have any other information about that.
No, I don't have any other information, but I do know that it is not the intent of the AUC to get in the middle of the arrangements that specific providers, whether this the institutional provider or the ordering provider, arrangement situation. So many of those arrangements are already in place, and I don't think we're here to dictate how the information travels between the two.
Another comment and question that came in, CMS transmittal refers to modifier QQ. I did not see this mentioned in the webinar. Is it applicable?
Is it still?
Fred, do you want to?
Yeah, Fred, is it still applicable? Is that a temporary thing?
Yeah, so, yeah, I was actually trying to get to the slide that talked about the modifiers. So the modifiers that are operational during this phase were listed in the change request. And so the QQ modifier was a modifier that was operational during a prior phase of the program. And so it's no longer applicable in this phase. You will notice probably, when you're looking through the listing, you will see that, there are new modifiers that kind of identify those situations where the information is not provided. And that's the MH, and that's currently used in this phase. The other modifiers that are used that are identified, the MA prior to the MH, really are identifying those situations where the QQ would have been used previously.
And yes, this PowerPoint is available. It's actually in the handout section of your GoToWebinar control panel right now. I'll also be emailing the PDF of the slide deck. Sorry, that was the next question that we got. And will CMS release additional information specifically with the criteria for 837I claims?
The K3 segment?
Yeah, if this is referring to the K3 segment, it is our intention to release a MedLearn Matter article on the usage of the K3 segment with the RFI, and of course to offer up some additional claim examples. For the AUC program, we are in development of that product. It hasn't been released yet. It hasn't been approved for release, but once it is, it will be out there. Additionally, we are working on a transmittal to do a systems update to make sure that that K3 segment for the AUC program is available for usage both in the 837I as well as in DDE, as well as in paper, to bring that information into our claims processing system and have it move through our claims processing system onto the other end products that are on our back end. And that particular change request for the systems changes will be incorporated hopefully or tentatively in the July 2020 quarterly release.
So Fred, I'm going to jump in and ask a question of you, something that came to my attention earlier today. There isn't a modifier that says that it's an inpatient diagnostic imaging service being performed. And my thought, and I just wanted to throw it out and ask the question, and see if I'm correct. My thought is that you would be looking at the place of service and know that it's an inpatient. Is that why there's no modifier specific?
Inpatient is exempt procedures, and you know by the bill type of bill code.
Yeah, in the institutional claim, that's correct, Todd. Yeah, and on the professional claim for the ordering providers on the professional claims, the place of service code for the inpatient is very clear. So in our claim examples that we had here, you notice the place of services for the outpatient hospital setting were used the 19, 22, and 24. And so we didn't have a claim example with the inpatient place of service because it wouldn't apply under the AUC.
Got it. I just wanted to clarify that and point that out if other people were thinking the same thing, that there's modifiers for the other exceptions, but not that one.
That was the final question, and we just hit 4 p.m. Thank you very much to all of our participants and, of course, our wonderful panelists. Do you have any closing remarks before we end the webinar?
I think my closing remark would be just to keep an eye on the CMS website. That's where the current information is being posted.
And this is Fred, and mine would be to, if you have continuing questions with regards to the AUC program, please go ahead and send those into that that email box that was highlighted here in the presentation, I think on slide 41, at the imaging AUC at cms.hhs.gov.
Well, thank you very much again to everybody that participated and our great panelists. So thank you so much, and look forward to future webinars, and hopefully we'll see many of you at the winter conference in a couple weeks. So until then, enjoy the rest of your week, and a happy Thanksgiving next week.